Hi there. My name is Dr. Kimberly Ernest, licensed psychologist, licensed professional counselor, president of PA Counseling, and founder of Live Up Counseling. And today on the How to Be Happy Hour, we will be talking about drug and alcohol treatment in an outpatient setting.
Hi, I'm Jonathan Reese, licensed professional counselor in the state of Pennsylvania, and I'm a clinical co-director here at Pennsylvania Counseling Services.
Hi, my name is George Acevedo. I'm an outpatient drug and alcohol therapist at our Reading Psych office.
Thank you.
Hi, I'm Kristen Wortleft. I'm a certified advanced alcohol and drug counselor, and I'm an outpatient therapist at York Psych and Allison Hill, and also the case management supervisor at York Psych.
Thank you. All right, y'all. So today we're going to be talking about drug and alcohol treatment in an outpatient setting. And we recognize that drug and alcohol treatment exists across the lifespan, right? Across the different levels of care. We can have inpatient, we can have different partial-based treatments. Obviously, you have medical-assisted treatment. It's very popular, gained a lot of popularity since I entered the field several years ago. At Pennsylvania Counseling Services, we provide treatment predominantly in outpatient setting. Typically, that looks like an individual starting with a level of care assessment, meaning they come in, it's about an hour, they fill out a whole bunch of paperwork, and then based upon their symptomology, based upon their substance use and the progression of their course over the course of their addiction, we make recommendations about what might be the best fit for them. Here at PA Counseling, we only offered two different levels of care. So we offer traditional outpatient, which tends to be about once a week. And then we also offer an IOP level of care, which is 3 times a week, up to 3 hours at a time. Occasionally, each of our levels of care also have additional recommendations, like maybe a co-occurring, where they come in twice a week with a little bit more intensive work looking at their mental health symptomology. We also have some specialty-based drug and alcohol groups. So we have one that's dialectical behavior therapy that looks at a more skills-driven treatment modality. Kristen, I also know you do the Seeking Safety group, which is designed to address concurrent substance use and trauma symptoms. We work with children, adolescents, and adults across the lifespan. We also, depending on the location, we have some ancillary services. So as you mentioned, we have case management. We always have different grant programs that come and go to support maybe women struggling with substance use and postpartum or pregnancy-related concerns. We also have certified recovery support specialists that provide a little additional support there as well. Treatment ranges anywhere from 3 months to 6 months, although the research does often suggest a little bit longer tends to be useful, so we're working on ways to expand that out. And then we also have in-person services, hybrid-related services, where they do some in-person and some online, and we're moving towards a fully telehealth model as well that would still have a few in-person commitments, such as drug testing and maybe individual within the community-based setting as well. So that is like the 10,000-foot view of the work that we do. From your perspective, what did I miss? What are some things that are inherent in the drug and alcohol treatment model that maybe I didn't mention? I know each of you have a very unique perspective or work in different settings, so I really want to open it up and hear more about how treatment works in your individual settings, because obviously I can speak to PCS as a whole, but with 14 different locations for outpatient, it looks a little different depending on where you're at. So tell me what I missed.
I will say the bilingual or Spanish-speaking services is something that we're fortunate enough to have at several of our locations. So you mentioned like hybrid models, that's available in York, and there's different resources for that as well, which I think is really important in many of our communities.
Yeah, thank you. And you lead much of our Spanish-speaking program in Reading, at least.
I do not.
Oh, you do not?
No.
Drug court is your
Yes.
vibe. Okay.
Treatment court is my thing, yes. Juan Ramirez is the one that runs the bulk of our groups.
Juan runs the bilinguals.
And we do have a full IOP, outpatient, co-occurring, and critical intervention, which is for the first-time offenders.
And that's all in all in Spanish?
All in Spanish.
Oh, that's such a gift.
Yeah, it's amazing.
Yep. We also have people to help translate for psychiatry because a lot of our folks do end up seeing psychiatry as well.
And our psychiatrists can provide medication management and a whole host of different things in addition to like mental health things.
Correct. So we assess for that right at the intake, whether or not somebody needs psychiatric services in conjunction to drug and alcohol.
So you are our primary guy when it comes to treatment court.
Correct.
Speak a little bit about what treatment court looks like. We have overlap in other counties, but nothing like our relationship in Burke. So I would love to hear a little bit more about your experience there.
I've been involved with treatment courts for, I think, 18 years.
Oh
So
my
I've
goodness.
seen it grow. It started out as just drug court and then got split into mental health court as being separate, as we saw it as a separate need. And from there, it's grown to DUI court and veterans court as well. So I attend all 4 sessions. The judge is wonderful. She's been with us for about 10 years.
Oh, that's great.
The DA is super supportive. I've seen DAs argue to not incarcerate people.
That's crazy.
It's a diversionary program to avoid jail time and to try to end the cycle of repeated incarcerations and reoffending. A client is applied usually by their defense attorney. So they go through an application process. We're trying to get them involved with treatment as soon as possible, but that doesn't always happen. So we have a new applicants meeting where we discuss each person, and if there's something that may keep them out of the program, then we discuss it and take it on a case-by-case basis. There are certain crimes that are not accepted at all, so violent crimes, gun charges, sex offenders, those kinds of charges are not brought in. Typically, we see the multiple DUIs, the retail thefts. We get a lot of aggravated assaults on police officers during mental health crises. And then that ag assault is dropped and they plead to a simple assault. So the client has to be willing to plead guilty to something. And usually they try to drop the severity of the charge so people can avoid felony charges as well. And it's a very intensive program. It is roughly 18 months where you're seeing a judge every 2 weeks.
Wow.
And the point of that is that the judge can respond almost in real time to behaviors with both service adjustments, is the term we're using now instead of sanctions, or rewards. So clients get small rewards at every session and then get bigger rewards along the way. We just opened up a treatment court store where a client is given almost like Monopoly money and then can build up money to buy pretty decent things in the store to reinforce positive behaviors.
That's really cool. That's really cool. Thank you for doing that overview. I know you've been so intimately involved with it for so long and really watched it grow. And you have a enviable relation. It seems like Berks County has really figured out a path towards, and I mean, I've worked in different counties and different programs. And you don't always see a high level of coordination across the judicial support, the DA's office, the public defender's office, treatment. You don't always see what y'all have. So it's a beautiful system that Berks County has developed. And I imagine it seems to be really positively impacting a lot of lives.
Our numbers beat the national average in terms of recidivism.
That's awesome.
What's the typical length of stay?
For a treatment court,
Yeah.
it's about 18 months.
Okay.
I've seen as long as 3 years
Yeah.
when people struggle, but it averages about 18 months. The shortest is 12.
Mm.
And then we try to keep at least with PCS, we try to keep the client engaged with services throughout the entire time.
Mm.
We try to not discharge until they're done with treatment court and a little bit past that.
I love that.
So we'll start out with IOP, drop down to outpatient, where outpatient is group once a week, individual once a week or every other week, and then drop down to just individuals. Eventually, we're down to maybe monthly individual check-ins. So that way, there's always some connection with treatment if there's an issue.
George, I really like the one time I went with you to drug court. Like that was like such a moving, like spiritual experience, gospel truth in lots of ways.
That is so cool.
Yeah, Berks is different. A very long time ago, they accepted that addiction's a disease and that it requires treatment, not incarceration. So that starts from the commissioners to the DA to the judges, and then trickles down into probation. I think that's the biggest difference with Berks that I've seen compared to other counties.
Yeah, I will say in York, it's not, the same. It's a little different, but we have a great relationship with the treatment courts there. And many of my clients have been involved with treatment courts over the years, and I can say it's just like life altering. Whether it's finding out that my client reads at a second grade level, so he's been involved with the legal system since he was 18, and like he can't do certain things that other people can, and like they figure that out in treatment court instead of just like the run-of-the-mill punishment on paper again, on paper again. And they really helped like change the trajectory of his life, at 50 something years old, because they finally asked why. Like, why does this continue to be a problem? And so, yeah, we have the same, all four different ones. And they even dabbled in family court for a while, which was very interesting. But yeah, I mean, it's a game changer for a lot of people.
When you think about like the best parts of the work that we do, like the reason why, because each of you, especially you, Jonathan, because you didn't start out as a drug and alcohol therapist,
No, I
did
did
you?
not want to do drug and alcohol.
No,
man.
you
No.
got drug into it kicking and screaming, didn't you? But I love that. I mean, I love that. So what is it about this work that drew each of you in, that sort of keeps you in the game? I know that the work is hard, but there's something about it that is so inherently rewarding. There's also a lot of challenges, and we'll get to those in a minute. But I want to start out with what really drew you into this type of work? What allowed you to stay in it post licensure, right? Because we also work with a lot of folks that they get licensed and they're like, see you later. I don't want to do this anymore. So, what is it about drug and alcohol work that either drew you in or kept you in? What's the best parts of this job?
Yeah, I know like a couple of things that have been big important for me in my journey and just figuring out my relationship with drug and alcohol is one, just coming to a point saying like this season of life, like I'm going to wholly devote myself to this right here. And like for me, that was like the starting point of it. Of like I know, like I had an idea of where I wanted to get to, and then things change and stuff like that, right? But like you devote yourself to it. Like I bought a carpet literally and called it the rug of acceptance and put it in my office for doing that. And through that, like I found within myself, like there has to be like an attitude shift of one, just that acceptance piece, but then secondly, like I have two choices. I can either choose to be miserable in the things that I do and not find meaning in it, or I can choose to look and say, I'm going to find the joy in where I am right now, and I'm going to intentionally find meaning in the work that I do here. So a big part of that for me, right, and which I think is also ties into like the part that I enjoys is it's like getting into the person in their story, getting into the person of what's going on with them, and finding that perceptions and reality sometimes don't necessarily align together super duper well. Like these are not people that are just doing it just for kicks and giggles, right? Like seeing like, oh, my interest was in mental health, and it's like there's mental health
There's a lot of mental
everywhere,
health.
man. I don't know if I've ever met a client that doesn't have mental health stuff going on with them, right?
Yeah.
So like for me, that was like a huge selling point for myself, and finding like this is joy right here, and finding what I want to do, what I love to do in this aspect.
The
Yeah.
co-occurring revolution in drug and alcohol was always quite curious to me. Because I had been working in an inpatient prior to like the big co-occurring pressure and language. And I remember thinking like, oh, we don't think they're all co-occurring. We're pretending that these are two distinct populations. And it's always been interesting to me, and it's double interesting to me now that it seems like we're sliding back that way, even like from a regulatory perspective. We got a notice from the state just a couple of weeks ago that said they're going to start doing dual licensing visits now. So OMSOS, the department that oversees mental health, and DDAP, the department that oversees drug and alcohol, are going to do joint licensing visits instead of subjecting us to two separate positive encounters. I don't know what to call it. I don't want to get myself in trouble, but they're gonna come check us out, and but they're now marrying those two things. And I recall doing this work early on, thinking I have yet to meet a client that before during or after their disease of addiction does not have some sort of mental health component, whether it be trauma, depression, anxiety, ADHD, PTSD. That just so many of these clients have both of those pieces. And once you peel off the substances, that's when you really see those other symptoms rise to the surface.
Mm-hmm.
And it's a unique type of treatment because you have to treat both of them kind of simultaneously.
Mm-hmm.
And I think it's also a population that, while it's challenging, it's one where you can really see progress pretty quickly. So that can be very rewarding because you can see the growth. You don't always see that with some of the mental health population. You feel a little stagnant sometimes with mental health population. With drug and alcohol, you can see the growth in insight and understanding and the real changes that they make, even in a short period of time. We have one person in the treatment court now where she came in kicking and screaming, medical marijuana, didn't want to stop, just very chaotic, and now she is grounded and managing her chaos, and you can see such a shift, and it's only been 6 months.
Yeah.
Sorry, my stomach's getting
Okay.
really loud. I even ate this morning. Growling.
So I fell in love with all co-occurring things when I was a CO at Cumberland County Prison. So I was like, I'm going to be a drug task force agent. I'm going to work for the FBI. And then I started working at the prison and I'm like, whoa, what is our society doing? And it was like a moral, and I just really was like, I got to do something else. I can't do this. So that's what made me go back to school and focus more on specifically addiction counseling, and a co-occurring route in that. And because I knew from working in the prison, mental health was that factor that kept people coming in like a revolving door. And I was like, well, if we did something about that, maybe they'd stop coming back, or maybe they'd live, and the amount of trauma, that people experience just being incarcerated for having a substance use problem, it just really pointed me in a direction of I need to do more. And so that's where I found my love and passion for all things reentry, all things drug and alcohol, and all things trauma and, substance use connected. It really pushed me in that direction. And during school, I really recognized the combination of trauma and an addiction, and how that they're like a vicious cycle that just keeps repeating itself. And if there's not a very distinct intervention at some point, it will go on until, unfortunately, death or a lifetime of incarceration. And so that's what really shoved me in this direction, and it's been wonderful. I haven't looked back since.
You've done a number of different types of programs in drug and alcohol, have
Yeah.
you not?
Yeah.
Have you found, I know that each program has its own strengths and has its own types of clients that are going to be the best fit for those programs. Have you found that there's one that's really captured your heart in the work that you do?
Yeah, so I started out very early on doing co-occurring IOP, and that was in that season of my life. That was it. That was my jam. Co-occurring IOP was an amazing chance to capture people straight from prison, straight from rehab, straight from off the streets and active addiction, and really help get them to buy into the concept of treatment and help get them to buy in, we want you here, and we're not just going to put you through the ringer of whatever your experiences have been before. We want to create a very unique, individualized experience for you. So that was really amazing then. And then I got the awesome opportunity to supervise our Center of Excellence, which is what it was called back then. So working with CRSs and case managers who oversaw individuals struggling with opiate dependence. And that was just an epic, place just to navigate individuals that are homeless, on the streets, in active addiction, and help them gain access to resources. And then throughout that's when I found the passion of the trauma-specific stuff, and that's where I wanted to really bring seeking safety to the table, because I thought that was just a very important group or a very important space for people to have access to that, especially men, because it's not something you find anywhere. And so that has been really important over the years to maintain that. And then recently, it's neurodivergence and addiction. That has fallen into my lap, and I love it, and I'm like nerding out on it currently. So,
I'm excited for that.
yeah, that's my new path that I'm going down on, but still heavily focused on the trauma and substance use.
I think it's like just feeding off like that new group that you're going to be starting up. Like whenever like I think about PCS and what we do and what we do well, we do group therapy for our folks, and we do group therapy well, I think, for our folks, right? And I think, like, you can look at the research, you can look at, different things that, other professional organizations are saying, right? Like, I think group therapy is very much like what our field needs right now. And I think if you look at like Yalom's like curative factors of groups, right? Like if you've ever sat in a group, both
It's
yourself or
spiritual.
facilitating, oh my gosh, yeah. So spiritual, so uplifting for so many folks who have like never had the experience to be like told like, you're a leader here inside this space. And they're like, I remember pulling people aside and they're like, what? I'm a leader? Like, yeah, people respect you, man.
Or you graduated something. Like,
You completed
you
something.
have this certificate of completion because you put your all into this and you did it. You finished this. Yeah.
And yet so many folks are resistant to groups out the gate.
Oh, absolutely.
I remember doing intakes when I started, one of my very first jobs at PCS was intake worker, where I would be scheduled for 40 intakes a week. So when I hear people complain today, I have very little empathy, I will tell you. So I'd be scheduled for about 40 intakes a week, one every hour. Obviously you'd have no shows. I have a permanent knot. You can't see it, but I have a permanent knot on my finger from writing during that season of my life. And it's never gone away. But back to back to back intakes. But so many folks want to be like, hey, I'm going to recommend you go to an IOP or a 1A level of care. And they'd be like, nah, I don't want to do that. I would rather not. But to me, I've grown up in the church and have had different spiritual experiences. I will tell you, there are many moments where I have felt a greater sense of spiritual connection in the context of a drug and alcohol group, in the context of taking clients to and from an ANA or AA meeting, than I have in many church-based settings, simply because that power of the collective, everyone leaning in, the way in which we support each other and challenge each other. It's just a beautiful space to be in. And it's so, I don't know, just this assumption that everyone's doing the best that they can with what they've got. And sometimes it's not that great, but we're all leaning in and there to kind of help and support each other through what is such a difficult.
Yeah, I just had a client answer the question during the intake of what did you find most helpful about your treatments, the previous treatments, which were groups, and the person said it was the first time that I understood that it wasn't just me, I wasn't alone.
Yep.
I'm not alone. Not what, as Yalom would say, unique in your own wretchedness.
Yeah.
It's a beautiful thing.
Yeah, I love when I start group at 9:30 in the morning and everyone's like disheveled and tired or like going through it, just going through it. And a lot of these ladies struggle to form relationships with women because they've been competition in the past or they have a lot of trauma with women. And so to see them come into that group week one, quiet, just distraught, hopeless, and then like as each week progresses, seeing them connect with each other and build this like empowered space for women to feel safe with one another and just see their whole mood shift from 9:30 to 11:30 and for them to recognize that, like how different they feel, like that, it's just a testament to what the group space does. And so at intake, I have to be like, just trust me. It's going to be so amazing. But I think I let people know at PCS, we have a salad bar. You get to pick what kind of croutons you want sometimes, and we can offer a more individualized approach to your group treatment. Because I think for a lot of our clients, they've just been thrown into that, like, cattle chute of treatment in the past, and they just think, oh, well, here we go again, another IOP or another outpatient group. But when they actually get in there, it's like, oh, wait, this is a little bit different. You're actually talking to me about grief. You're actually bringing topics to this group that I actually need to learn about and I need to hear. You're teaching me about boundaries. And, once that happens, you can see that complete shift, like you were talking about. It's like a complete 180, and that buy-in starts to happen. And then you have people that stick around for 7 years.
And it's always the topic they really don't want to talk about.
Oh, absolutely.
I've discovered. Like, that's the difference maker right there. When they come in, and I remember having a client many years ago, he came in and he said, hey, I'll talk about anything, but I'm not going to talk about his father had died by suicide. He said, I will not talk about my father's suicide. I'll talk about anything else. But we're not going to go there. We're never going to go there. Well, obviously.
We went there.
Obviously. Immediately. I'm like, okay, yeah. But in the back of my head, it's like, that's the due north then.
Yeah.
Like, it's the thing we're never going to talk about. And not because I'm cruel and I just, like, I enjoy torturing my clients through forcing them to talk about things they don't wish to discuss, but because, like, that's where the sticking point is. That's the thing that's kept you stuck. That's the thing that you have 2-3 years of recovery. You have 2-3 years of continuous sobriety, and then you have a relapse around the anniversary of that date, and you, have a setback in prison surrounding his birthday. And like when we start to put the timeline together and we start to realize, then I remember with this particular client, I think I brought this topic up 3 or 4 different times, and I always honor their, if they say we're not going there in this moment, we're not going to go here in this moment. But I just notice, like, hey, I'm noticing his birthday's next week. You're having a really hard time.
Yeah, it becomes a theme in a person's life.
Is now the time we talk? And no matter how many times you say I'm not going to talk about it, you can refuse to go there in treatment. It's not like you can refuse to go there in life, though. It's going to keep showing up for you. And then after that is where I feel like that's the hook. Like, that's where we get you, because you talk about it and you realize, one, that you survived it, that you can do hard things, that you can talk about these shitty, painful, horrible moments. And once you do it, you might make better sense of it. You might come out the other side doing better. So, but I always find that that's the secret sauce, is the whatever it is you refuse to talk about. Once we do that, that's where the magic is.
My favorite thing is when people realize the reality that they had painted and have been habitually telling themselves all these years. When they do finally actually talk about it, they realize that's not even what actually happened. And they're able to recognize, like, wow, I've been telling myself this thing that has made me blame myself for so many years. But when I actually talk about it and don't just keep repeating the things over and over, I realize I actually had nothing to do with that. Like, it wasn't, that wasn't even the reality, what I've been telling myself. And I think that's such a powerful moment to realize, just because we tell ourselves something doesn't mean that it's actually coming from a fact.
You discussed that PCS is like a salad bar, and we let you pick the croutons you put on your salad. And I like that. So I want to unpack that a little bit further, right? So we have a lot of, predominantly our treatment recommendation tends to have some sort of group component, based on all the reasons we already said, that there's a lot of power in that. It supports individuals in really understanding some certain skills. It also gives them the community-based support that is so essential to recovery. But I think it's important to mention that we also are more than happy to add psychiatry or medication management if that's helpful. We're more than happy to add individual sessions if they have some individual work that they need to do. We're more than happy to have. I love doing couples work. Couples and family work, to me, it's my favorite thing to do, because when individuals are lost to the disease of addiction, their relationships are often the very first thing to go. And the absence of relationships, recovery is really, really hard. We also have in some of our counties, and if we don't have it, we know community resources for this, for certified recovery support. We have certified family recovery support, case management. What other croutons am I missing? Are there other pieces that tend to be available in our communities that are not?
DBT.
Oh, DBT. Yes, we add those pieces in. Dialectical behavior therapy. I'm sorry, what was the other?
EMDR.
Oh, yes, some trauma work, EMDR. Other pieces there. Anything else I'm missing?
I do know that in like some of our clinics in some of our counties, we do work pretty closely with PRS for like Vivitrol. And I know like I've seen clients like that just do wonders for keeping them engaged, especially with the standard that PRS holds of like, hey, like being in treatment, like
Yeah.
seeing treatment is vital.
Yeah.
So I think that's like a really, really important piece of a lot of stuff we do.
I am. Yeah, I think that you bring up one of the biggest challenges of drug and alcohol work, right? We've talked about some of the highs. We'd be remiss if we didn't touch on the lows. And that premature attrition, man, it's a bummer. Especially because, at least in my heart, I've always carried that quite heavy. Recognizing and ultimately, as a provider, we are not responsible for our clients' outcomes, right? We are responsible to make sure we show up. We are responsible for using evidence-based practices and empirically supported treatments. We're responsible for maintaining that non-judgmental stance and ensuring that we have a high level of treatment excellence. But you can come with the best salad, and as my kids will often say, no thanks.
Gross.
It's green? No. So we do also have clients that vote with their feet, clients that don't show up, clients that experience a lapse or relapse and need a higher level of care. Um, Clients that don't last as long as would be helpful. Oftentimes our clients are mandated, so they have to come for a portion of treatment. And when they successfully complete that mandate, there are times where we recommend, hey, you're done with your mandate, but we'd suggest you do X, Y, and Z from here. And they say, no, thanks. And that's always really hard. What do y'all do with those moments? The premature endings, the relapses, I know we don't call them sanctions anymore, but I forget what words you said.
Service adjustment.
Service
I
adjustments.
like that.
I do too. What do we do on those days, or what do y'all do on those days to keep you in it?
I think that as long as I give it my all in the session, then I can let the person go with kind of a clear conscience. I can say I did everything I possibly could, and then the rest is up to them. They need to process the therapy session for the rest of the week,
Yeah.
and then come back next week and talk about how it impacted them. I have no control over what happens afterwards. I currently have 5 former clients incarcerated for relapse, but I find that they end up coming back to us.
Yeah. Absolutely.
Even when there's been a relapse, when there's been an issue, a new offense, they tend to come back to us because we do good work.
Yeah. I think that it's just very important to realize that if love cured addiction, we wouldn't be here. And so we can really give 4,000,000%, but sometimes people just aren't done yet, and their disease is very powerful, and it pulls them away quicker than we can keep them in. And even if they're doing well for a while, like things pull them back out. But to your point, people come back. I've been called every name under the sun, and then a year later, hey, Kristen, you were right. I needed inpatient. Recently, I had one of my favorite clients. I worked with him. He had the longest time sober that he's ever had. He unfortunately decided to try meth for a while, which meth is never the answer. And
Just clip that.
is never the answer, please. Remember that.
Never the answer.
But in the middle of like a meth-induced situation, he thought of me and his CRS, and he reached out to us like immediately. And now he's back doing actually trauma work for the first time in his life. And so like that's the stuff that it's not always going to be pretty. But when you get these calls years later, and they're like, hey, I'm doing really well, but my mom passed away. I should probably talk about this with you.
Sure
And that's,
should.
yeah,
Yeah,
good
good
job.
insight.
Exactly. And so I think like there's not going to be days where your clients love you or they're very happy with what you're saying or they're happy with their recommendation, but you don't know how sticking that boundary through and enforcing that and loving them enough to say, no, like this is what I'm recommending. You don't know how that's going to turn out down the road. And so it is important to just, stick with that and realize it might not be okay today, but by sticking with that, hopefully it's okay in the future.
Kristen, I think really much like very much like what you're saying there, right? All three of us have served in the communities that we've been in for a hot minute,
Yeah.
right? And it's like there's a lot of heartache that comes with that because then you hear of certain things on the news, right? You see different folks come in where it's like, oh my gosh, I can't recognize that person.
Yeah.
They look so much different in not a good way.
Yeah.
Um, so like there's that very much that heartache piece that comes with it because like I know in Columbia, small clinic, right? Like people wandering in through the doors, and it's like oftentimes like I was the one there to like see you when you first came in, see to hear you again, right? And like that being so incredibly painful, and also too like seeing that glimmer of hope, right? Like at least they know they can come back here for this. And like there's an aspect too, I don't know if you guys find this, but there are some people that I'll just be driving down the road, man, and like they will pop into my heart, right? And I'm like, holy smokes, like
Yeah.
that person was fun to work with, and I wish that they wouldn't have left treatment
Yeah.
when they left treatment because I'm always right? So I see what your life could be, but you want to choose to go a different direction.
Yeah.
That's where the realm of like, man, I'm gonna do some outreach calls, man. Like I'm gonna reach out to your PO, man. Like I'm gonna send you that letter.
And they're
I'm gonna
pissed when you
all
do
that.
it, but I'm
Oh
doing it
yeah,
because I care about you. I don't want you to
Exactly.
disappear and die on me.
yeah.
My number
100%.
one is that you stay alive long enough to
Yeah.
get this.
Yeah. And like that's extra work, right? But it's like
Yeah.
Yeah.
I once had a mentor that said like one thing that's helped him and his wife survive their marriage is like one of the phrases of like do the little things.
Mm-hmm.
And it's like, yeah, I'm a millennial, man. I hate making phone calls, right? But like it's a little thing that's gonna show this person I love them, right?
Yeah.
I hate emails as much as the next dude hates emails, right? But like if I reach out to your PO, that's me loving you.
Mm-hmm.
And I also want to prevent, I don't want to
Yeah.
have to discharge you. I don't
Yeah.
want to kick you out of treatment and have you need a new eval down, like once your PO does catch up with you. Like my big thing is when I used to run IOP, if you no-showed IOP, this is back when we had breaks during IOP. I don't know if we still do or not. Sometimes we do, sometimes we don't. I need a break within 3 hours. So on the break in that halfway point, I would always run it 10 minutes over. So we would go into like 8:10 and then have a 10-minute break in the middle. On that break, I would call whoever wasn't in group that day.
Yeah.
On that break, I would email the PO to whoever wasn't in group that day. And pretty quickly, my attendance increased dramatically because they knew I was going to harass them if they didn't come. But also, my premature attrition decreased because I wasn't kicking guys out of group for missing. Because I also can't give you a spot that you're not willing to use and withhold it while these other folks sit on a wait list, right? So I can't have you no show group after group after group. There's some liability to me in that as well, but I'm not even all that worried about that. I'm much more worried about like prematurely kicking somebody out than keeping somebody in too long. But what you notice is that if I reach out to your PO and say, hey, Jonathan didn't come to group today, that PO might visit you tomorrow morning, and I bet I'll see you in group tomorrow afternoon. And then that ends that revolving door, which we so often see in the drug and alcohol world. And I want to touch on one more thing that you mentioned, which is that even if it ends in premature discharge, which I never want to see, sometimes that doesn't mean, or sometimes that individual still finds recovery.
Mm-hmm.
And I think so often as providers, we put that premature discharge or that client that ghosted us, right? We put that into the unsuccessful category because that's the type of discharge it is. But I've also had clients that circle back years later and they're like, oh, yeah, I totally ghosted you. And I went to jail for a while, but then I got into treatment and then I had this and then I had that. And like, look at me now. And so it was based on those seeds that were planted prior to that premature discharge that's helping them stay in recovery today. And I think that's a beautiful thing, even when the individual course of treatment didn't go according to plan.
Yeah, I'm all about seed planting. I think that's just a huge part of drug and alcohol work, especially because when you're fresh out of inpatient or fresh out of an incarceration, what I have to say might not mean a whole lot when you're trying to find housing and your PO's breathing down your neck and you need to find a job and you got fines to pay. But hopefully, when things settle down, like those seeds that were planted will start to grow and it will all make sense at that point.
We used to have a therapist in our Lancaster City office many years ago that was in his own recovery as well. And unfortunately, he's since passed away, but he had given me permission to share this piece of his story. And he was in his own, he was a drug and alcohol therapist by the time I met him, but he had his own narrative of disease of addiction. Had been incarcerated on and off, had sold drugs, had gotten himself into a fair bit of trouble over his early years. And he had gone to rehab 11 times. He had had 11 stints in rehab over the course of his recovery journey. And he said none of them ever lasted. He'd go to rehab, he'd come out, he'd stay sober, he'd abstain for a couple of months, and then, he'd see the right guy or have the right opportunity to use again, and he'd be off to the races again. And by the time I met him, he had had 20 plus years of recovery, this, that, and every other thing. And I said, so tell me the secret. And he said, well, the secret is there are things that I learned in my very first stint of rehab that keep me sober today, but I wasn't ready to use those skills or lean into those pieces early on. And yet they're essential to my health and wellness today. And that was sort of his message to every new provider that came into the field, because it's heartbreaking. I mean, it truly is. If you work in the world of addiction, you're going to lose clients to overdose. You may lose clients to suicide. You're going to lose clients to incarceration. There are moments that you're going to work really hard with a client that's going to go on to do some not great things and find themselves in pretty serious trouble. And I think therapists carry that really, really hard. But I think it's important to recognize that the story's not over until it's over. And sometimes those early seasons of treatment are what that person needed, even if they weren't ready for it yet. What advice would you all have for somebody new to the field? Those bright-eyed, those baby Jonathan Reeses, fresh out of grad school. They want to be a private practice clinician with mental health only, but we offer free supervision for licensure, so they're going to hang in there with PCS for a minute. What is your advice to that reluctant drug and alcohol therapist, or maybe the really passionate drug and alcohol therapist, but they are brand new to this world? How would you advise them to develop a sustainable practice?
Don't assume that you're an expert.
Mm.
Ask your clients when you don't understand a term they're using. Be okay with not knowing,
Mm.
because you're in a completely different world that you know nothing about, and if you pretend you do, you're not going to connect.
And it's a completely different world that's ever changing.
Yeah.
And if you're not in that world, from a lived experience perspective, I just learned that kratom can be consumed in a tea format. I had no idea. I thought it was different than that. And someone's like, oh no, they can make kratom tea. I was like, well, there we are. There we have it.
And then lawyers will argue with you about it in court for an hour. That was fun. No, you should not mix barbiturates and kratom. Don't do that.
Another reel.
Yeah, that's another reel.
Just took a new therapist out behind our office, which is a pretty high traffic area, to show her what a drug bag looks like, 'cause she's never seen one.
Gotcha. Yeah.
And then that therapist calls me on Friday and says, hey, there's somebody in our alleyway beside our door that doesn't look so hot. What should I do that they never would have noticed? Because, right,
Yeah.
They had a mentor, they had somebody that could take them
And show.
on that journey. And I think like very much for me, like find the people, like for the new clinicians, like find the person, find the people that are going to help you develop in a way um, that I don't know that you need developed, right? Like
Yeah.
in a deeper way, right? So I know like for the folks that have been really powerful for me inside of my development and trying to figure out how to love drug and alcohol work. One, I have the people that are very practical in the things that they taught me, right? Like my licensure supervisor, right? Teaching me very practical things that I had no idea even what is meth. I don't know, man.
Yeah.
Tell me what meth is. But then very much like those themes, right? I remember sitting down with my one of my first intakes, looking at them, hearing their story, them getting pissed off at me, and like, holy smokes, this is people. This is like every person that I've known in my life, like for my personal stuff, and that stuff coming up and finding those people that are going to work with you on those themes there with it. So, like for the early career clinician, right? If you want to have a shot in doing any sort of work, you need both those types of people in your development.
Yeah, I was gonna say continued education to like come off of what both y'all said. It is an ever changing, no matter what the drug trends were last year, they're going to be different now. And so I think knowing that no matter how long you've been in the field, whether you just started yesterday or you've been in it for a decade, keeping track of like what those trends are and figuring out the best ways to do that. I mean, I love a good Drugs Inc. episode. It's going to tell you all the latest stuff straight from the drug dealer's mouth. So just finding different avenues of like gathering that information and, like you said, asking, like, what are you talking about? What is that now? That's how you get the information and understand what's going on in your specific community. Also, like the drug testing reps, like the
Oh, yeah.
from Drug Scan and Quest, like they're great. They are filled with knowledge about local substance use trends and things like that. And they've been very helpful to come to the clinics and just kind of share what they're recognizing on a county-wide theme and a statewide theme as well.
I think that's something that I often also talk to my community partners about. Like if I have regular meetings with probation and parole, or even during those like little touch points, I'm always really curious about what their themes and trends are. I think it tends to be really cyclic as well. Like many, many years ago, when I started in the field, like meth was all the rage.
Yeah.
Everyone was doing meth. And then we went into a really heavy opiate season where we started seeing an emergence of a lot of fentanyl. We started seeing quite a bit of opiate related overdoses. That's where we saw Narcan distribution really dramatically increase. Um, and now it feels as though we're like baby stepping back into like a meth season or some sort of upper. And I think if you look at drug trend history, that's very common. Like you have a season of downers, and then like we had the marijuana of the 70s to the cocaine of the 80s, to the opiates of the 90s, to the meth of the early 2000s. And so we're basically like speedballing as a culture. We love to go uppers, downers, uppers, downers, uppers, downers. But I think it's really important if you're doing this type of work to have awareness of what's going on in your community. Because additionally, if we're doing this type of work, we're going to have individuals come into treatment impaired. You're going to be sitting across from a client and they're going to be acting a little funny, or they're going to be nodding off, or they're going to be so hyperactive that their words are almost coming too quickly for their mouths. And we need to have some awareness about what's in our communities so that we can intervene appropriately and safely in those moments.
I think too, like as you were talking about the culture, right? Like in that regards, right? Even for those folks who maybe aren't, abusing, dependent on substances, right? Like we all have our own themes, right? Where we're going and following that trend as a culture in different ways, right? So like even just like for the early career clinician, right? Like along with the education, along with finding your mentors, taking that step back and saying like, man, like I am you. Maybe I'm not, using meth or heroin or anything like that, right? Like, I am you, just in a different regard, somebody that still needs to do development, somebody that um, may have, different themes within our life, different things that we're struggling with that maybe aren't substances, but are still addiction nonetheless. So I think there's that really important aspect of like, catch yourself, because you share a lot more in common with that person than what you care to realialize.
I love that, Jonathan.
So do I, yeah.
That egalitarian piece. I think so often we view ourselves as separate from our clients. And who among us hasn't struggled with a coping skill that's gone horribly wrong?
Yeah.
I sure have. I mean, mine is ice cream, but still, it's not helpful in those moments. And I think you introduced that as a culture, we've been trained to believe that addiction is some sort of like moral failing. And I would love for us to retire that belief altogether as a society, because truthfully, nobody ever picks up a substance and says, you know what I want to do? Destroy my entire life for this drug. Like, no, oftentimes their lives have become so painful or so unmanageable that they have to reach for some sort of chemical anesthetizer, and then unfortunately they discover something that works, something that does take the pain away, something that allows them to tolerate some of their discomfort, because many of our clients come from intersecting environments where they have a lot of really painful factors. You talked about grief, we've got trauma. We often serve populations that have very low socioeconomic status, high community violence. I know that y'all serve a lot of the Spanish speaking population who, based on different intersecting factors, have less access to resources, or are immigrants within our communities, or may even be undocumented and not have access to some of the resources that other citizens do. And I think that's a beautiful thing about our work, is that we show up and we meet you where you're at. And no part of us looks at you and says, well, if you just had a better moral compass, you wouldn't be using drugs. No, we're saying you and I, we're all turkeys in the same turkey soup. You just figured out a different type of turkey grit than what I'm eating, but we all struggle with it at times, right?
And that like isn't meant to be easy, right? For us
No.
to step into that, and like hardly anything worth doing is truly easy, right? So like there is an aspect where I think at times, right, like early career clinicians, right? Jonathan Reese was this person, right? Where like, I just want to do the easy stuff. I just like want to like be the private practice person. And it's like, life isn't easy. The work that we do isn't easy. If we're looking for easy, then maybe that's our own addiction that we're trying to figure things out with, right? Like
Crisis
nothing
of
is worth
comfort.
it. Yeah.
You bring up a very good point with that.
And I think it's important for an early therapist to recognize that addiction is effective as a coping skill.
Yeah.
Yeah.
It does have value. So when you're ripping that coping skill away from that person, understand that they're going to struggle, and we have to replace it with other things.
Yeah.
It's been effective for a long time for a lot of people.
Yeah, in my groups, I refer to it as an abusive relationship. And just because you know it's abusive doesn't mean it doesn't hurt to leave it behind. It's still a grieving process, and it's an important part of your recovery to look at it from that perspective, because some individuals, that substance has been with them through every single major event in their life. And so to sit there and be like, it's bad, don't do it. It's like, well, how has it been bad? It helped me get here today, And I think respecting that relationship and realizing it's not something that is so easily let go of. And instead of focusing so much on the don't do drugs, focus more on what drives that and what can replace that. How can they create a life worth staying sober for?
I love that. I think that that's the mechanism that we're driving towards underneath it all, right? That life worth staying sober for. And sometimes that life is filled with joy and connection and all the beautiful, wonderful things that life has to offer. And then sometimes it's painful and difficult and challenging or God forbid, boring. I remember working with a lot of my clients once upon a time after they got through that early recovery season, which is chaos. It's just sheer chaos. Like parts of your brain are coming back online that haven't been online for a minute. You're feeling new feelings that you've never felt before. There's a lot of emotionality. There's a lot of different pieces there that you're rediscovering. But then you sort of hit this like maintenance phase and it's boring.
Yep.
And you do boring things and it's predictable and you wake up and you go to work and you come home and you get your kids off the bus and you make dinner, rinse, repeat. And I remember working with a lot of clients, they're like, but my life is so boring. And it's like, but isn't that great? Do you remember when it wasn't boring?
Yeah.
But to get ready for it is so like, so many clients so struggle in that season of
Yes.
recovery.
Yep. They hit the year mark and growth doesn't happen overnight anymore. And they get sober people problems. And that's very different from active addiction problems. And although there's gratitude there because it's drastically a different sort of problem, it can absolutely trigger relapse. So it's definitely something to work through as well. I always tell them to get out of that yellow tunnel at the park and go play on the damn swings. You got the whole park now. You earned the whole park. So go use the metal slide that's gonna rip your skin open. Like go do something else. You don't have to stay in that little tube anymore. You're not in active addiction. Go do like a scary tour of Pennsylvania. Like Google it. It'll give you a map. Like just go do something. And sometimes just giving that permission has been really helpful. It's like, oh yeah, I can like go to the beach. Like I don't have to worry if I'm going to get sick 1 hour into it. Like I can do those things now.
I had a client years ago that he loved his drug of choice, but that wasn't really his addiction. His addiction was the hustle.
Yeah.
He was addicted to the chaos and the dopamine and cortisol tied to like all of the drug attainment behaviors he not enjoyed, but he enjoyed the high of like burglarizing a home or all these different things. And so one of the things we talked about is, all right, so how do you have the stimulus, like that stimulus seeking part of you is not going to go away. You can't get into bar fights anymore because you're going to go to jail for a really long time the next time you do. What can you do? And he's like, I love go-karts. I forgot I love go-karts. I was like, well, buddy, we're going go-karting. And like he got really into go-karting and then he went from there to do like, I don't remember what they're called, but like those like dirt track race car things that are real local here. I don't know. He got into all of that stuff and like that was his lifestyle and that's what kept him in recovery because he needed that excitement. But he needed that excitement not from a home invasion. So he needed to find a different path towards it.
Yeah. For my wife, it was traveling. She was a gypsy soul. So, like, getting clean and like just doing the 9 to 5 every day. And like the thing, like, we had to plan little trips once a month to just go and spontaneously see something somewhere. And that like kept her little gypsy heart very happy and content. So like just figuring out ways to translate that into something that you can do in recovery is, maybe you need to go skydiving. I don't know. Like, go do it. Just check it out. See what happens. My one client hates bowling. He now knows that because he tried it. And he decided he's never going to go bowling ever again in his entire life. But that's part of figuring out your identity in recovery. What do I like and what do I not like? And if you are the chaos seeker, you got to find something to harness that energy so it doesn't lead you back into the addiction chaos.
Yeah, I've recently had a client return to me in a mental health chart. He's struggling because he's institutionalized.
Yeah.
So he's sober 2 years or so, but doesn't know how to live without the structure. And he's looking at, I'm going to end probation soon.
Oh, yeah.
That's scary.
Yes.
Yeah.
Yeah.
Very
So
scary.
one realization he recently had is I can take a vacation.
Mm-hmm.
He's never been on vacation
Yep.
because he's been on paper since he was a teenager.
Yep.
Now he's in his 30s and doesn't know how to live like an adult.
Yeah.
But he can really appreciate the fact that his bills are all paid. He's like, I don't want to lose that.
Yeah. I enjoy that.
Things up to date, but there's no one else to do.
I think that's so much the realm of like as you're like conceptualizing like what are the different stages I engage folks, the different levels of doing so, just knowing uh, one, going back to um, keeping them engaged for a longer period of time, right? You don't get to the identity work like this second they walk in the door,
Yeah, exactly.
right? Not all of them.
Yeah.
Sometimes you will, but
Yeah.
unlikely, because first you're working on that stability
Yeah.
stage, right?
How to use a planner.
Yeah.
Like, yeah.
Basic
Yeah.
things like that. Yeah.
Yeah.
So it's like very much that realm of like as like early career clinicians, supervisors, right? Like talking about with a clinician, how do you conceptualize and view these different stages of the journey that a client's going on? Because I know in my own naive heart, whenever I first started, right, I started with identity stuff first, and like they couldn't handle that,
They're not there yet.
and that's like a growth point that I had to engage with. So just taking that stuff to supervision, right, like making that a conversation
Mm-hmm.
in the clinic, right, about what are the different stages, how do we engage with people differently along the journey.
Yeah. And just realizing that success looks different for every single person we encounter. So, someone's success might be that they didn't punch their manager in the face this week. Other people's success might be that they got their GED. Another success might be that they took the bus somewhere. So they engage in a social interaction, like realizing that it's not about necessarily what we want to see our client do, because obviously we want them to do amazing, but it's about what is going to make them see progress in themselves and what that looks like for them specifically, what their values and progress are.
One of the things that we notice with many of our clients is that once they get through that early stages, they start recognizing like what their relapse prevention plan is. They start understanding what their triggers are. They start to even recognize that they have a disease of it. I mean, many of our clients start in that denial phase, right? They come in and they're telling you, no, I just need an eval. I'm not here for treatment. Or they let you know that they don't, um, they could stop whenever they want or whatever it is. Once they get through that particular season, then we often see them start to show up and really value their treatment. But then I think a new thing sets in, which is like this belief that, oh, I can use just a little bit. Or like the hubris maybe that had diminished during active addiction. Because I think in active addiction, folks oftentimes are in more the depths of their suffering, right? They start to realize, I don't want to live like this anymore. I can't have this anymore. Once they get a little bit further away from it, maybe they start romanticizing it again. They start remembering the good times and, maybe I could just use socially or whatever it is, fill in the blank. What do you all often do in that season when they're out of that early crisis moment? Maybe they're even finding that those maintenance behaviors, but now they're starting to think, you know what? I can be one of those people that only drinks in moderation. What's your approach to a client that comes in with some of those questions?
I think that's where our different types of outpatient groups come in, and also like ancillary services. But I also think that's important why, wow, English is hard. Okay, that is why it is important um, for individuals to stay in past that, oh, I'm got to do this for 12 sessions and then I'm done.
Yeah.
Like realizing that you used for 25 years, 12 weeks ain't it. Like it's not gonna do it, give yourself a fighting chance and hang out a little longer, because I think some of those spaces to work on that, like, why do I think that maybe alcohol is a good idea now? And like if you're in like a DBT group or you're in a trauma group, you can start to ask yourself that question, well, what maybe am I avoiding that's making me think that alcohol could be a good idea? Or what am I having problems regulating that is making me think that alcohol could help me regulate? And so I think it's harder to ask those questions when you don't necessarily have some of those services in place that help give you just the psychoeducation of why that even comes up. because it comes up for various reasons throughout all of recovery. You know, you could be 20 years clean and you'll be like, oh, well, you know what sounds good? Some heroin today. And it's like, well, I know that that's not definitely a good idea, but why am I thinking that way? And having that conversation and being able to realize what's driving that, what those underlying themes are. And I think that's what a lot of our outpatient groups are good for, whether it's co-occurring or, just relapse prevention or trauma or any of that. It helps realize what those underlying themes are that have driven that addictive behavior for so many years in the past.
Yeah, and I think that when you have established that relationship, and the client knows that you're not going to judge them, they're going to be willing to come to you with that behavior. And sometimes it's not a chemical. Sometimes it's gambling. Sometimes it's sex, it's shopping, whatever. But they're able to come to you with that behavior and say, "Hey, I did this, and now I realize that it's going to do this to my life."
Yeah.
When you bring up the point that sometimes they get the substance use under control, but these other compensatory behaviors creep up. So I recall working with a lot of clients that they would stop their substance use, but they would develop a very similar pattern with sugar or porn or spending or gambling or fill in the blank. And it was often this almost like behavioral replacement strategy where I'm not going to use meth anymore. It's like, yay! I'm like, but I am going to the casino 4 times a week. And it's no. Like, it just, so helping them recognize when those new patterns creep in, because while their drug of choice might have kept them alive and been an effective coping skill for a very short season, continuing those same patterns with a new drug of choice, if you will, rarely ends well, or I've not seen it end well in most instances.
I think one of the things is I'm a huge fan of groups, right? So
Yeah.
like if clinicians are seeing things where it's like someone's been with us for a while and somebody's maybe struggling in one specific area, and then they look at their caseload, right? Like you need to take an inventory of your caseload, and you're like, holy smokes, I have like 3 people on my caseload with this exact same thing. Hey, Kristen, George, you guys have people on your caseload like this, right? And it's like, bro, write up a proposal. Let's come up with a group to serve these people, because I guarantee you if it's on your caseload in your local clinic, what's that looking like? And then
Yeah.
right as we enter in the telehealth realm, how many more folks are like that across the board?
Absolutely.
And then the other thing that I was always a big stickler with my folks is like, hey, like you don't have to always go to AA, NA, Celebrate Recovery, all that stuff. But if you want to actually have a chance to make this stuff successful, and secondly, if you ever want a chance to be done with treatment here, you gotta go to at least X, Y.
Supports.
Yeah, you
Yeah.
gotta check it out. And so many of them, they would go and they'd be like, "Bro, that was BS. Don't want to go there." Okay, good. Well, you tried it out and you know that group's there and you know faces now if you need that. And other folks, it's like, man, where can I find some other meetings like this to go to? It's like, yeah, that's what we're looking for, because now you have somebody other than me, other than your PO, that you can talk to about this stuff. So don't, like, for clinicians, right, don't lose the heart of like saying, hey, you need to try this out. You need to give this stuff a shot. And if it's BS, it's BS. But
And also, though, those groups are not just for your clients.
yeah,
Like, if you are an early career clinician starting out in this field, I, I can't recommend more highly that you should make a meeting, that you should get to an NA meeting, get to an AA, make sure it's an open one, right? So, like, make sure on the website it says it's an open meeting, meaning that it's open to those not in recovery. But if it's an open meeting or like a speaker fest or like there's lots of different events, go educate yourself, learn, hear these stories. I don't think there's a better way to receive some education in this particular area than to lean that direction. And you talk about telehealth and all the opportunities that's opening up, and I'm so excited for this next season at PCS. I was reluctantly excited. I'm going to admit it. I was not excited out the gate, but I am so tremendously excited for us to launch our DNA telehealth program, and it's because of that reason right there, because of the success that you've had in running seeking safety groups and having some of these telehealth things, I think historically when I started thinking about drug and alcohol telehealth here at PCS, my brain went back to the pandemic.
Yep.
Traumatized.
Yes.
And like immediately,
Start twitching.
I was like, no, I'm not doing that again. And I think it was because it was horrible.
Yeah.
Like we weren't ready for it. We didn't have the resources. We didn't have mechanisms in place. The whole world is shut down. None of the resources that we're used to like relying on for our clients were open. So I think when initially we started talking, I mean, the background on this is that the Department of Drug and Alcohol Programs in the state of Pennsylvania last fall approved DNA telehealth only, meaning telehealth only providers, institutions that have no bricks and mortar locations within the perimeter of Pennsylvania are now permitted to open up shop in Pennsylvania as telehealth only, which I don't love. I don't love it because it's not always the path. It can be a good path, but DDAP didn't ask me and they did it anyway. And so that's the world in which we existed. And I did, in fact, scream into the void for a while. I yelled, I was upset about it. I think we also see a lot of telehealth startups come into Pennsylvania, make things really hard for a while, ultimately fail because these startups realize there's no fucking money in it anyway. They close up, they leave, they abandon all their clients after providing subpar care, and we, as the local providers that are established and has been around for a while, pick up the pieces. So I'll try to regulate myself and speak from a more regulated space moving forward, but I didn't love the idea when they opened it up. And since then, and since I've accepted that our DNA program, our DNA telehealth program, will not look like it did in the pandemic because we were able to be intentional about it and move that way, not under duress, but with intentionality to ensure that we're a better option for these clients than these California startups that show up and don't have maybe some of the same relationships and resources underneath. So I'm going to dive into that for just a moment and speak to that because I think we'll share this particular clip with many of our clients. But here at PA Counseling, we're starting a DNA telehealth program. We're hoping to have it live next month. Might not happen next month. We'll see. I have a meeting later today. We'll find out for sure. But where we're going to have intakes via telehealth. So one of the issues we run into is we often don't have enough intakes in a given clinic to support some of their programming. If we have intakes in that clinic, or if we have intakes that are available, the individual would actually participate with their intake completely online. They would need to present to, I think we're going to use Quest, but they would need to present to a lab prior to their intake so we have a good understanding of what they're presently using. And while we always ask our clients what they're presently using, we do have a trust and verify mentality. Because not everyone tells the full gospel truth when asked what their present substance use is. And then we can refer that individual to a 100% in-person group. So we will have an IOP entirely via telehealth. We will have several outpatient 1A levels of care entirely via telehealth. We already do have quite a few of them. So I know Eric Peroni runs 1A level of care. You have your seeking safety group. You're also adding the neurodivergent group, which hopefully we can speak a little bit more about that. And then these individuals would get their care completely online with the understanding that we can recommend hybrid when it's appropriate. So if this client's really struggling with telehealth, we may say, hey, you can't do telehealth anymore. If this client is showing up and all you see is like, just their eyeballs, or maybe the ceiling fan, or maybe they're on and off, or maybe they are violating confidentiality for having other people in the room during the group, or maybe, fill in the blank. There's lots of different reasons or ways in which somebody could not be successful in telehealth DNA. Those individuals may be referred to an in-person group within the clinic, or they may be referred to some sort of in-person component. So they might be asked to do some individual within the bricks and mortar clinic. They might be referred for CRS or case management within the bricks and mortar clinic. And then again, throughout all of it, they would be repeatedly required, essentially, to stay in DNA telehealth. They'd be required to do the urine screens online. We're still figuring out some of the insurance pieces, obviously, but I anticipate it'll be quite successful, and I'm really looking forward to it. I'm looking forward to it for a few different reasons. One, the research shows it's about as effective as in person, which surprises me, but it's the truth of the matter. I think the other thing that's for many, I think there is a percentage of the population that really needs in person as well, according to the literature. Another data point that showed up in the literature that I thought was really important to pay attention to um, is that it's not just about the success of the program, but individuals are much more likely to actually stick with and complete DNA telehealth versus in-person component. So they have less issues when it's surrounding transportation. Many of these folks have lost their license, so they have to get transportation back and forth. They don't have to worry about child care or some of those other pieces. Sometimes they can jump right on before or after work, or even have like an extended break at work and go to a private and secure space and participate from that location. So when it comes to accessibility, when it comes to engagement, when it comes to long-term sustainability, I think DNA telehealth is really promising for a whole host of different things. But Kristen, I know you've done a lot of DNA telehealth over the years, and you did it in the pandemic under duress, but I anticipate you've done it since then with more intentionality. I'm not sure about either of you and your experience in doing DNA telehealth, but I'm really curious to hear about. I don't want to talk about 2020. I'm still unpacking that. But DNA telehealth now with intentionality. What's been your experience with it? What's worked? What hasn't? When do you need to refer somebody to a higher level of care? What have we discovered about telehealth drug and alcohol work? Not under duress. I can't emphasize enough. I don't want to talk about 2020, but all the other stuff. Let's go there.
We've had a pretty fair mix of in-person and telehealth at Reading Psych since the pandemic. Eric's groups are in our clinic, so I do refer a lot of people to those groups. And just having those boundaries when it's not working to say, this is not working, we need to switch things up. Or having a combination of the telehealth group plus in-person individuals, that's been very successful.
That's what I'm hoping that we can do a little bit more of, that we can have that telehealth group where you're broader frequency so that some of those barriers are reduced, but you still have that in-person touch point.
Yeah, I mean, I work with women a lot who are CYS involved or who lack a lot of significant resources. And so I will say that offering a telehealth option has been a game changer in regards to their willingness to commit to treatment and also just be able to show up. Like I had a client who had a hip replacement. She would have never been able to come into the clinic and sit through a 2-hour group in these chairs. You know what I mean? But because she was at home, she was able to still access this treatment when she needed it the most. I mean, that's a life altering surgery, and just being in recovery and having to navigate, pain medication afterwards and stuff like that. That's the time where you need your group the most. And if it was in person, I don't know how that would have turned out for her. And that's just one example of many. Whether it's childcare options, summer's here now. So a lot of, people have children that they don't have childcare for. They don't have
Women specific
Yes.
that when you're looking at research based on like specific factors,
Yeah.
women are far more likely to not go to treatment because of childcare.
Yeah, it's a huge issue. And so when I tell them, hey, this is via Zoom, you just see this relief like rush over their face very often. And then also, this is a trauma group. So they struggle in groups, they struggle with setting boundaries in groups. And so they're able to build these relationships from the comfort of their home without worrying, like, am I gonna get too close to someone because I struggle with boundary setting, and then that person might jeopardize my recovery because I'm trusting them too much, or so it helps develop relationships that are oftentimes felt as much safer. And I worried a lot about like the ability to connect in a group space over Zoom, because it has its challenges. But I will say these ladies really, I mean, and they're all over the state, so they come together and they connect and they share the different resources that they have. And I will say that's another great thing about telehealth is the access it allows to all of the different clinics. So if, in Harrisburg, up until very recently, we finally have a Spanish speaking therapist, thank goodness. But we've had to utilize York Psych. We've had to use, Reading because we didn't have those resources there. So having those options via hybrid or telehealth has gained access to resources that weren't necessarily in that county. So with Seeking Safety, it's a very unique group, and now women from across, all the different various locations have access to it instead of just York Psych, which is how it was before. So I think that's another big plus with that.
I also think about the smaller clinics that we have that,
Or
you know,
communities
they,
in general.
oh
Yeah.
yeah, like they work their tails off. They have like groups available, but they can't have groups at all hours of the day, right? So like Rebecca Hall has like a daytime group. So like the amount of freedom it's been for some folks to say, hey, we want you to do a group, and I hear of this really real barrier that's going to happen in the evening when our groups are. What if we offer this time to you? Then that way it's not between those things. Then we can get into the real conversation. If you don't want to do group, but there's at least options, greater options that can come through the telehealth realm that clinics don't have to be all things to all people.
Yeah.
Work schedules, distance.
Yeah.
I mean, how many clients do we work with that, or counties we serve here in central Pennsylvania that, many of our clinics are in like the center, or like the city seat or the county seat, like in Schuylkill County, we're in Pottsville. Schuylkill County is a big county though.
Yep.
And some folks could have to drive an hour and 20 minutes to just get to that clinic. So having that telehealth option really increases that accessibility, increases show rates, and ultimately, hopefully, access to recovery for these individuals so they can develop that more sustained recovery process. Any other telehealth experiences that you all have had? We're still figuring it out, but I think I'm really excited for the direction that we're going.
I think that coordination amongst the professionals involved is absolutely essential. It prevents triangulation. It prevents just thinking the other person's picking up the slack of the other person. And I think constant communication helps paint a picture of how that client is actually doing in that space. So there's sometimes that seeing someone in their home environment compared to them coming in person, you get to see maybe a little bit of a different side of things. So if they're struggling like with a hoarding situation, or they seem very scared in their home, like those are conversations that are important to have that you might not pick up on if they're only coming in person, and you don't necessarily get to see some of that stuff that is accessible when you are doing a telehealth session. Or you're sitting there doing a session and there's gunshots going off in the background, which is very true for a lot of the clients that I work with. And so that helps you understand what it is that they're actually dealing with in their home and in their community. Recently, one of my clients was like doing group and is in the process of about to have to get evacuated because of the fires. And so it's like there's all these things that are going on within the communities that sometimes, for me at least, I've felt more, like I feel like I can see that more in a telehealth space than someone coming into the comfort of my office where they feel very safe there, but that's not what they get to leave to go home to. And I think that opens a whole other conversation in therapy. Like, I'm giving you all these coping skills, but like, does it even apply to what you're dealing with in your daily life with the stuff that you have to see every day in your community?
I've also found that it not only gives you insight into their daily life, but gives you more access to it. So when I mentioned it already, I believe in the power of the collective. I believe when you're lost in the disease of addiction, you often have ruptures within your most important relationships. And I think resolving some of those ruptures can be the secret sauce or the difference maker between sustainable recovery and relapse. And so I'm often like chasing these individuals' partners or adult children or, adult sister, whatever it is, anybody else who's on your side and in your corner, but you may have hurt over the course of your active addiction. And we need to work through some of those pieces in order for them to be able to be an effective support for you and for their own needs. They may need to work through it. In different ways. And I found telehealth increases accessibility to those types of sessions so much more, because then you're not navigating two work schedules plus the therapist schedule. Or maybe they'll say, like, hey, you're the one that's been using. Why should I go to therapy? And it's like, I get that. I understand. Could you just come to a Zoom? And they're like, okay, I'll do that. So it's also like a lower barrier to entry when it comes to pulling in their ecosystem or some of their natural supports. I want to thank you all for spending so much time here with me today, for unpacking some of these different things. Is there anything left unsaid? Are there any pieces that we haven't talked about here today that you think would be useful in the area of DNA telehealth, drug and alcohol work in general, that of the provider? Anything left unsaid before we finish?
I would highlight, especially for the newer therapists, boundaries.
Oh,
Ooh, yeah.
They're so important. I've had a lot of long-term clients that have entered the field as CRS, and that's always something that we talk about within therapy is what are your boundaries? Talking about transference, counter-transference, um, but just the boundaries that I've seen people break and how it just cascades.
yes.
So even in telehealth, having those boundaries and having those difficult conversations of if you don't change this behavior, telehealth is not going to work.
Yeah.
I think for clinicians starting out here at PCS, there's a mentor that they can go to for support to ask questions. There's the person of the therapist groups, right, where they get to work on the intersection of their stuff and the work that they're doing. There's a weekly meeting that we do just to teach the nuts and bolts of different things, right? There's people that have been working here for a long, long time. And there's, in a lot of our clinics, there's folks with a history of like being in recovery, right? So like using those people, leaning into those things. And if you need to go back to a POTS meeting, come back to a POTS meeting. If you need to use your treatment team meeting time to have conversations, use that time because that's what it's there for. That's the purpose of it.
Yeah, I was going to touch again on another benefit of telehealth, like especially where the two clinics are that I work at. For some people that don't live within the city, it's very triggering to come into the city for sessions. And so I will
They
say,
used to come into the city for
Exactly.
other reasons.
yeah, they have complete physical reactions coming into any large city, let alone the one that has trauma triggers around every corner. So I will say that is something beneficial, having more access to more appointments without having to, necessarily be in the same space that you used to use substances in. So I think that's just been like another benefit. And yeah, there's always someone to go to if you are a new clinician. Like, you don't have to be fearful of what you don't know because there's so many people around you that know the things. So, not being afraid to ask. And yeah, I echo the boundaries. That is so essential for multiple reasons when doing drug and alcohol work and checking in on the codependency stuff. Because, like I said before, love does not cure addiction. So, being afraid to, like ruffle some feathers is not great and it will get you in some really sketchy spots. So, using those groups and supervision and mentors is really important for your development.
You make very good points there. And as you were talking, I think my closing thought that I'm most excited about with DNA telehealth is the possibility to have more specialized groups. I come from a season where we used to try to do the specialized groups within the clinic, and we would sometimes have tremendous success. I remember years ago, and you were around when Jobana was here, and she was pre-licensed. She had a mental health. She had a group that was mental health for Spanish speaking women that had concurrent um, physical health concerns. And I remember when she came to me and she said, I want to start this group. And I was like, girl, you're pre-licensed, so you can't take any private insurances. You want it to be women, Spanish speaking, mental health, physical health. There's no way you're gonna have enough clients to succeed. Man, she proved me so wrong. She ran that group like full to bursting until the end of her season with PCS, and it was amazing. But it doesn't happen like that so often in a clinic setting. So often in clinic setting, you have 2 or 3 clients that would really benefit from this. But 2 hours with only 2 or 3 clients, whew, that's a lot of time for 2 or 3 people in a group setting. But telehealth, like you're starting one for the neurodivergent community. Would you speak a little bit just to what that is? Because that is so new, and to give an example of kind of what I'm talking about.
Yeah, so something I've noticed recently as I'm stabilizing trauma symptoms in many of my clients is that they are identifying these other mental health factors that have been a part of their story since they were very young. And they're realizing they're somewhere on this neurodivergent spectrum. And some of them have actual diagnoses. They've been able to do that work with neuropsych evals or autism evals throughout their time in services. And some of them don't have diagnosis. They've just realized I'm a little neurospicy and I need some support with that. And I think there's not a lot of resources out there, because I've looked, where
I looked for you.
yes,
as well,
yeah,
and I
you
couldn't
looked as
find it.
well. And when you've got addiction and then you've got these other comorbidities of whether it's physical health or PTSD or bipolar, and then you sprinkle some neurodivergence in there too, it's like a recipe for disaster if you let it be. And so I think it's something that has maybe been touched a little bit in drug and alcohol treatment as time has gone on. He's like, no, not at all. But my goal is to give a space to those individuals who it's not a differential diagnosis. So you're not neurodivergent because you're on all of the methadone ever and you think that you have ADHD. That's not what we're looking for here. But like actual stable recovery, and then realizing how neurodivergence could impact your recovery journey at some point or exacerbate other symptoms that you have, like PTSD, bipolar, medication compliance, things like that. So had to make a curriculum because there wasn't one. And so I pulled in a lot of stuff like unmasking and the dangers of that versus like the pros, cons of that and how to do it safely. Boundaries, relationships, creating environments that are safe for you as a person instead of just trying to fit into all of these different environments that are more neurotypical. Time management, time blindness, financial stuff, brain detox, food, caffeine, how drinking 75 Monsters a day is not going to help your situation. You got to eat fruits and vegetables sometimes. Nicotine and Monster is not going to help your mental health. I know, it sucks, but so just capturing a lot of that stuff. I actually interviewed each of my clients and said, what would help you? And they all gave me different ideas. And so that's what helped me kind of build this curriculum up. So I'm very excited about it because it's really built by the clients and what they've told me over the years that they need. And so I'm really excited to provide this, service to them and hope that it helps them in this next season of their recovery.
I'm really excited for you.
I think the addiction field has really ignored specifically ADHD, adult
Yes.
ADHD.
Yes.
Because it's like, okay, you're an adult with ADHD, but we're not going to treat you with stimulants because you have an addiction history. So
Yeah.
we're just going to ignore that part,
Yeah.
not even deal with it.
Look away.
Yes.
Yeah. Just pretend that's not even yeah.
Right, but now you're sober 2 or 3 years and you're struggling with the inattention, the
Yeah.
impulsivity, all this stuff, and it's affecting your family, your work life, and we need to deal with it.
Well, Kristen has a group coming. And Kristen, I'm so excited for that group and all the possibilities that DNA Telehealth have to offer. Well, I want to thank you all for taking the time to connect with me here today and talk through these many different things. We do have a couple of podcasts for the How to Be Happy Hour coming up. The next one that we'll be in the studio on is Cousins. Talking about cousins. I love cousins. Cousins were an integral part of my childhood. So we'll be unpacking that particular really important relationship. I think after that, we have a grandparents pod coming down the line. And then I think I'm officially out of ideas for season 3. So we might go ahead and wrap, but we'll see. We'll see what I come up with. As usual, we are always accepting questions from our audience. So Kim at howtobehappyhour.com. We would love to hear your questions. Also, if you would like to submit a topic or an area where you really would love to hear a panel of experts unpack this particular content area, we are very much open to that as well. So thank you so much for listening, and we'll catch you next time.